Eddie Kilbride here with Kilbride Plastic Surgery. Today's patient story, no triceps, no problem. So this 13-year-old has what is most likely an unrecognized birth-related brachial plexopathy on the left side. And as you'll see, he's got global underdevelopment of the musculature of the entire left upper extremity, but he can do virtually all things with the exception of terminal finger flexion and, most importantly, elbow extension. Specifically, he and his mother presented because as soon as he tries to raise his arm up, he cannot support the elbow above gravity, and he is unable to keep the arm extended, as shown here.
You raise your arm straight up as high as you can, as high, touch the sky, and okay, try to hold it up, bring it closer to your head, yep, okay, and then hold.
And here's just another illustration showing that he has absolutely no activation, no muscle function of the triceps.
Now can you extend your elbow, just straighten your elbow out, straight, and relax, and straighten again, and relax, good. And what about do the same thing on this side, lift you up, and then bend your elbow, yep, and then straighten out, perfect, and bend again, and straighten out, good.
So in that assessment, I'm asking him to extend his elbow. He's extending the wrist, but he has absolutely no elbow extension. So I decided to proceed with him for a functional muscle transfer, in this case, an innervated Latissimus Myocutaneous flap from the ipsilateral backside. So here's a picture intraoperatively demonstrating opening up the arm, and isolation of the triceps tendon is shown here. I then turn my attention to the back and dissect out the latissimus muscle. This is kept innervated throughout through the thoracodorsal nerve. And you can see there a subcutaneous space interval between the arm wound and the back wound. That interval was developed and the flap is passed underneath that subcutaneous tunnel and delivered to the arm as shown here. Now, at this point, the muscle is basically reconstructed and shortened, tubularized to basically create a new triceps muscle as shown here. You can see the skin paddle on top of the muscle, the undersurface of that skin paddle from the back. And then there's the inset enclosure of that muscle. The muscle is extensively weaved into the patient's existing triceps tendon. And then all incisions are closed as shown here. And so here he is at 6.5 weeks post-op.
Here with now 6.5 weeks out. Let's put your hands all the way up, above, high above your head. Straight up above your head. Straight up. Excellent. Okay, you're able to hold it. That's fantastic. And then back down. Perfect.
And then here he is at 1.5 years post-op.
Up as high as you can. Very good. Excellent. Okay, you can relax. Perfect.
You can hear my enthusiasm there. So this is a nice case. I hope you enjoyed it. It's a case of no triceps, no problem, illustrating that while as nerve surgeons, we have to be able to offer the comprehensive treatments in regard to nerve procedures. If you're doing complex nerve reconstruction, you have to have in your arsenal tendon procedures and functional muscle procedures to complement that, to be able to offer the patient kind of the appropriate treatment option regardless of when they present to you. So I hope you enjoyed this case. If you're interested in other functional muscle transfers, check out the case of the jumping muscle transplant, which I have on this channel as well. As always, make sure your surgeon's board certified. Ask for pre-op and post-op pics and videos. We'll see you for the next patient story.